Friends, colleagues, fellow advocates for well-being, take a moment to consider the invisible wounds that many carry. Wounds inflicted not by accident or illness in adulthood, but during the formative years of childhood. Today, I want to talk to you about the critical yet often overlooked aspect of healthcare, the profound and lasting impact of adverse childhood experiences, or ACEs, as the CDC calls them. Firstly, I'll be discussing what exactly the problem with ACEs is, and then the reasons and the context behind them, and then finally reviewing what we can do to correct our neglect of ACEs. Menachem Lisi, a pediatrician with the NIH, shares this story. Imagine a child facing abuse, physical, emotional, or sexual. Picture a home where neglect is rampant, where basic needs of food and safety are unmet. Envision a household shadowed by domestic violence, substance abuse, mental illness, or the incarceration of a parent. These are ACEs, traumatic events experienced before the age of 18 that can have an indelible impact of lifelong health and opportunity. The statistics are staggering. 3 in 4 high school students have reported experiencing 1 or more ACEs, and alarmingly, 1 in 5 has experienced 4 or more. These experiences are not isolated effects affecting a small segment of the population. The original ACEs study, conducted by the CDC and Kaiser Permanente, found that 67% of Americans, adults, had experienced at least one ACE, and nearly 13% had 4 or more. Notably, the study was done in a population that was 70% Caucasian and 70% college educated, demonstrating that ACEs affect individuals across all socioeconomic strata. The consequences of these early adversities are far-reaching. The ACE study revealed a dose-response relationship. The higher the ACE score, the worse the health outcomes, Nadine Burke-Harris reports, who is one of the initial leaders of the ACE recognition movement. Individuals with an ACE score of 4 or more face a significantly elevated risk of numerous health problems, including a 2.5 times greater risk of chronic obstructive pulmonary disease and hepatitis, a 4.5 times greater risk of depression, and a 12 times greater risk of suicidality. Furthermore, those with an ACE score of 7 or more have triple the lifetime risk of lung cancer and 3.5 times the risk of ischemic heart disease, the leading cause of death in the United States. Preventing ACEs could potentially avert millions of cases of serious conditions. Estimates suggest up to 1.9 million heart disease cases and 21 million cases of depression could have been avoided. Moreover, ACEs can contribute to risky behaviors such as smoking, alcohol and drug use, and multiple sexual partners. But the impact goes beyond risky behaviors. Exposure to adversity affects the developing brain, immune system, and hormonal systems, even altering how our DNA is read, as found as a CDC study. This can lead to difficulties with attention, decision-making, and learning in children. As adults, individuals who experience ACEs or toxic stress may have difficulty forming healthy relationships, unstable work histories, and struggles with finance, job stability, and depression. Tragically, these effects can be passed on to their own children, perpetuating a cycle of trauma. As Dr. Robert Block, former president of the American Academy of Pediatrics, stated, adverse childhood experiences are the single greatest unaddressed public health threat facing our nation today. Given the profound impact of ACEs, why isn't routine screening and intervention a standard part of healthcare? A 2010 study surveyed family physicians in Massachusetts to understand their practices, skills, attitudes, and perceived barriers regarding screening adult patients for childhood physical or sexual abuse. The findings revealed a significant gap. Less than 1/3 of providers reported usually or always screening for childhood trauma, and a substantial 25% reported that they rarely or never screen patients. This is despite the fact that histories of childhood physical or sexual abuse among adults primary care patients are estimated to be between 20 to 50%, which is an NIH figure. Several factors contribute to this lack of routine screening. One major barrier is time constraints. Overwhelmingly, the NIH revealed that physicians reported not having enough time to ask about a childhood abuse history, which stood at 89%, or to evaluate and counsel victims, 91.9%. The pressure of competing primary care recommended also plays a role. Furthermore, many physicians lack confidence in their ability to screen childhood abuse. Nearly 40% of respondents reported no formal training in screening adults for childhood abuse histories. This lack of training contributes to discomfort with inquiring about psychological issues and a feeling that there is little they can do to help patients who reveal a history of abuse, and that figure was actually about 45.1%. Some physicians even incorrectly believe that a history of childhood abuse is not a medical problem, standing at 12.8%, or that their patients are unlikely to be victims of trauma. The focus of current guidelines also contributes to the problem. While professional organizations recommend routine screening for current intimate partner violence, these guidelines primarily address adult partner violence and do not address screening adults for histories of childhood physical or sexual abuse. This lack of clear guidance leaves many physicians unaware of what to do when their patients come in with ACEs. As the study concluded, there's a clear need to develop training programs when to suspect trauma histories and how to approach adult patients. The good news is that this is a solvable problem. By understanding the impact of ACEs and implementing evidence-based strategies, we can begin to heal the wounds of the past and improve the health and well-being of individuals and communities. Firstly, routine ACEs screening should be integrated into primary care workflows. While concerns about time are valid, research has shown that a brief 10-question ACE screening tool can provide valuable information without significantly lengthening visits, especially when implemented through a team-based strategy, another NIH study found. The CDC validated several ACE screening tools as well. Importantly, screening should not only occur when the practice is prepared to provide treatment, referral, or emotional support. Secondly, we must embrace trauma-informed care. This is not about asking when trauma happens. It's a fundamental shift in how we approach patient care. Trauma-informed care acknowledges the widespread impact of trauma, recognizes its signs and symptoms, and integrates this knowledge into policies and practices to avoid re-traumatization. This involves creating a safe and confidential environment, being respectful to the impact of trauma on all patients, regardless of whether they disclose their history. And key principles include emphasizing safety, promoting autonomy and choice, and applying these principles universally throughout the healthcare system. Simple shifts, like warning patients before asking invasive questions and asking permission to touch, can make a significant difference. Thirdly, comprehensive education and training on ACEs and trauma-informed care are essential to all healthcare professionals. The training should address the prevalence and impacts of ACEs, how to screen effectively and sensitively, and how to respond to disclosures and available resources for support and referrals. Medical schools, residency programs, and continuing medical education initiatives must prioritize this crucial area. Finally, we need to adopt a community and public health perspective. Childhood trauma is not solely an individual issue. It is often rooted in community problems and socioeconomic issues. Healthcare professionals can advocate for policies and support community organizations that address the root causes of trauma, such as violence prevention programs, mental health services, and initiatives that promote safe and stable environments for children. So finally, we have the knowledge and the tools to address the silent epidemic of childhood trauma. By recognizing the profound and lasting impact of ACEs, overcoming the barriers to screening, and embracing trauma-informed care principles, we can transform the healthcare and break the cycle of adversity. This is not just about treating illness. It's about fostering resilience, promoting healing, and ensuring that every child has the opportunity to thrive. Let us have the courage to look this problem in the face, acknowledge that this affects all of us, and work together to build a healthier and more compassionate future. Thank you.